Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being.
We are happy to welcome Dr. Gary Kaplan, a pioneering leader in the field of integrative medicine, board certified in family medicine, pain medicine, and medical acupuncture. Welcome.
Thank you very much. Delighted to be here.
In 1985, you founded the Kaplan Medical Center for Integrative Medicine, a multidisciplinary medical center focused on chronic pain and illness. Will you explain the collaboration approach the center takes with its patients?
Absolutely, and I think it's crucial in terms of the way we do medicine. So the center is 4 different physicians. We have 2 family physicians who also specialize in integrative medicine, functional medicine. We have a PM&R physician who does work with joint regeneration, PRP, prolotherapy, which I'm also trained in. And we also have a nutritionist on board. We have 4 physical therapists, one of whom specializes in craniosacral therapy. Another specializes in pelvic floor work. We also have a psychotherapist as part of the team, and we have a meditation trainer as part of the team as well, and an acupuncturist. And in addition to that, we have nurses and support staff. So all told, there's about 25, 26 of us under about 10,000 square feet in Virginia. The whole concept here is it takes a village. The patients we're seeing are very complex, and over the years, as success begets success, what happens is the universe then starts providing you with more and more complex and difficult patients. So it becomes impossible for any one of us to be truly expert across the board of what we need to be doing. And so this integrative approach with both practitioners and multiple skill levels allows us to help a wider range of people. Where we started off focused on chronic pain individuals, we are now very much involved in chronic illness. And so we see the full range of people who are struggling with chronic pain, chronic illness problems. And if basically in our practice, if you don't have chronic pain and chronic fatigue syndrome and sleep disturbances and difficulty with focus and concentration, you probably didn't need to be seeing us. We see people from around the country, and we've had a good amount of success. We're very pleased with how much the patients have taught us over the years, as much as what we've been learning from attending conferences and also being able to speak at conferences.
Right. Can you share an interesting success story with us?
So, yeah, we've had a number. We had one kid who came in to see me. He had suicidal depression, had attempted to kill himself by hanging. He had been in and out of psychiatric care for a couple of years. And the model we use is one of a neuroinflammatory model. So we think that depression and chronic pain and chronic fatigue syndrome and POTS and PANDAS are actually not individual diseases so much as they are symptoms of an underlying neuroinflammatory problem. And so with that approach in mind, we then go, okay, what are the things that set off the neuroinflammation? And then we do an extensive look. We know what the targets are. The targets are microglia in the central nervous system, mast cells in the central nervous system. And we also know that the acquired immune system becomes part of this problem. So then the question becomes, okay, if those are the mediators, what causes these things to get set off? And then we start a long involved history to look at this stuff. In this particular kid's case, what we eventually found was that he had celiac disease. Now, here's a kid, he's 17 years old. He's been treated multiple psychiatric physicians and hospitalizations. But they don't think they're treating depression. They're treating a symptom. They're not treating a neuroinflammatory disease. He didn't have any bowel problems. He didn't have any of the other manifestations that you would typically see with celiac disease, but he unquestionably had celiac, both in terms of the blood work and in terms of the duodenal biopsies that we had performed on him. And by removing gluten from his diet, by actually removing some of the cross-reactive foods, by doing work to seal his gut, and again, this is taking a team approach to accomplish this. We're working with the nutritionist. We also have our psychotherapist on board participating in this. We're using acupuncture also to help quiet down some of the inflammation in the central nervous system, as well as medications. And as we integrated this entire approach for him over the course of a year, basically he cured. The depression completely resolved. He was off all antidepressant medications, back in school, life is good, he's back to their normal kid. So that's the kind of things that happen when we start thinking about things as neuroinflammatory as opposed to saying it's depression, it's chronic fatigue.
Right.
And then we start looking in different places to go find better answers.
So I understand you were appointed to an advisory committee.
Yes.
With Health and Human Services. Can
Correct.
you talk to us about that?
So I had the privilege of being appointed to an advisory committee by Dr. Sebelius at Health and Human Services, specifically with regards to myalgic encephalomyelitis chronic fatigue syndrome. And what these committees do is they're kind of the interface between the public and HHS to make recommendations for directions that HHS should take in terms of better serving the community. So what we do is we meet several times a year. We have hearings in which the public is able to testify before us and tell us what it's like having these conditions. And then we're able to take this information in and make recommendations to the Secretary about what changes in policy can potentially mitigate the problems that we're hearing about in the community. HHS, remember, is the umbrella organization. So CDC is under HHS, NIH is under HHS. So we have representatives from all of those departments present, as is Social Security and Medicare, as part of our committee. And so then what our job is to do is to listen to their stories. And the stories are absolutely heartbreaking. I mean, when I first started on the committee, chronic fatigue syndrome, myalgic encephalomyelitis, was first of all not acknowledged as a real disease by the overwhelming majority of the profession. Indeed, it was a career ender if you were a PhD or a physician who wanted to go in and study this stuff, because you weren't getting any money, you weren't getting any support, and that was the end of the discussion. So the majority of physicians in the community dismissed this, and we heard horror story after horror story about these people who had been horribly abused by the medical profession, told they were faking, told that they had depressive disorders, and about 25% of people with ME/CSF are housebound, bedbound. I mean, we're not talking tired, we're talking disabled fatigue. And there's not much they can do. And so you have to work with them. They were getting horrible advice in terms of treatment. And finally what happened was we convinced the NIH to hold what's called a P2P conference. It's one of the ways that the consensus gets developed about evolving diseases. The P2P conference acknowledged that ME/CSF existed. Big deal, because now the NIH has given its imprimatur on it and said, yeah, it's a real thing. We had also authorized $1 million for IOM to do a study on ME/CSF, and 6 months later the IOM came out with their recommendations and their acknowledgement of that. So what happened then suddenly is we now have a real disease, so these people are now being validated. We can talk to the profession, and then what we had to do was outline a path in order to get the information out to as many people as possible. How do we educate physicians? How do we educate school nurses? How do we educate PAs and nurse practitioners? So we developed programs for that. We talked about development of centers for excellence. At the time, the amount of money being spent on ME/CSF was only about $5 million a year. Now, considering you're talking about probably 1.5 million people struggling with this disease, versus, say, multiple sclerosis, where you've got about 800,000 suffering with the disease, and the NIH budget for that is $130 million.
Oh, wow.
So we were dramatically underfunded, and so we put forth, and I was on a couple of the subcommittees that I chaired, in order to create centers of excellence for ME/CSF and to create educational opportunities for physicians in particular, so that we can get these people the care they rightfully deserve and need.
Right. That sounds like important work.
It was exhausting work, and you know, a lot of work for no money, but the privilege of being able to really serve this community and make a difference in medicine. So I was really honored to be able to be on the committees, and I spent 4 years on the committee. So it was good work. I'm very pleased.
Now, you're a well-established pioneer in integrative and patient-centered medicine, having served in governmental committees with the NIH as a clinical professor and more. But let's go back towards the beginning for a moment. How were you first drawn to the alternative model of healthcare than the standard at that time?
So interestingly, I think I was always drawn to the alternative healthcare model, if you will. I actually started, I attended an Esalen conference when I was in college. Met a guy by the name of Hector Prestera, who was one of the first physician acupuncturists in the country. And I walked up to Hector after his presentation and I said, I'd like to come out and study with you for a year. And he said, sure, kid. I don't think he ever expected to hear from me again. A year later, I show up on his doorstep after I graduated college. We moved out here, ended up in Monterey, and I spent a year studying acupuncture with Hector. And so that was really my introduction to what would become integrative medicine. So I then went to osteopathic school, hoping that the osteopathic profession would be kind of the leading integrative medicine field. It was not. It was unfortunately more along the lines of very good allopathic medicine and a little bit of osteopathic medicine thrown in. But I did a lot of manual therapy training, and to this day still do manual therapy in my practice. I haven't a clue how you practice without it. Mm-hmm. I then, after leaving there, I went to study with Gladys McGarry, which was kind of at the time the place you went through, the Casey Clinic down in Arizona for a year, and was on the board of the American Holistic Medical Association, and had the privilege of being mentored by Norm Shealy, who was a chronic pain specialist. And so I've always kind of been involved in the community. I helped create the American Academy of Medical Acupuncture in the mid-90s. NIH at that time was doing consensus conferences. The consensus conference was the way that the standard of care was established in the United States, or at least one of the ways back at that time. And they were a combination of scientific meeting and town hall meeting. You've got 1,000 people in the auditorium. You've got a jury of 12 physicians and community representatives, and then you have experts in their field presenting to you. So I had the privilege of being involved with 2 of those consensus conferences. One was on the use of meditative techniques and relaxation techniques for treating sleep disorders. And I was a jury member on that, and we, at that point, approved meditative techniques, relaxation techniques for these conditions. What happens is that gets published in JAMA. And so that kind of changes the whole psyche of the profession in terms of how we think about these things. And then several years later, I was on the planning committee and then one of the subject experts on the consensus conference on acupuncture, and had the privilege of being part of that whole process. And indeed, the jury at that time published a paper in JAMA that said, yes, acupuncture deserves to be part of the conventional medical establishment. It had indications at the time for low back pain, for nausea and vomiting post-operative, and chemotherapy-induced nausea and vomiting. So, but once it's in, it's in. And that now gave the NIH imprimatur on it that said, yeah, this is real medicine, this is real science, and frees up dollars in order to have research done, and frees up the profession to have an honest conversation about this, as opposed to having to hide in the shadows, if you will, and being somewhat disparaged. Go, no, wait, I got papers in JAMA, I've got papers in a number of the top journals that say, yeah, this is real stuff. So that's where I started off with all this stuff. And then what happened was the American Academy of Pain Medicine said, you know, in 1999, they wrote a white paper that said, you know, this is doing opioids is a perfectly appropriate thing to be doing for people who are suffering with chronic benign pain syndromes. It had been working for the people who had cancer. Of course, they were all going to die, so the addiction didn't matter on them. We changed the term from addiction to dependence, thinking that that would somehow clean it up. And then, as you know, we subsequently created a massive problem with an opioid addiction problem in this country, with over 17,000 people dying 2 years ago alone. So it was a bad decision. And what I saw and what we saw in the clinic at the time was we looked at the opioids and we're going, wait a minute, we're getting the seesaw effect that goes back and forth between depression and chronic pain. And we were going, what's that about? So my answer to everything is research and form a study committee. So I was privileged at the time to have some colleagues from NIH willing to come over, colleagues from Georgetown willing to come over, neuroscientists, psychiatrists. Also Tara Brock, who's a meditation expert, willing to join us as part of our conversations. And what we started to understand as we went through the literature and as we were talking about this is that really what we were looking at is different faces of the same condition, both of which were neuroinflammatory diseases. And that got us looking at the innate immune system. And then the question became, okay, if you're looking at the innate immune system, what is the innate immune system? The answer in the central nervous system made it easy for us: microglia, astrocytes, and mast cells. And then the question is, okay, what sets those things off? Well, once you know what the mediators are of the inflammatory response, you can then say, okay, what is it that turns those on? And that completely changes your diagnostic interview. So now what we find is what sets them off is toxins. Guess what? Heavy metals, mold toxicity, the garbage we're seeing in plastics and everything in the environment. We see problems with long-term stress, especially people who've been abused. We see problems with chronic Lyme disease, chronic Epstein-Barr, and a number of infections. And we also see things with hypoxia. Number one cause of hypoxia, sleep apnea. 85% of the people in this country who have it don't even know they have it. So only 5% are truly diagnosed and treated on a regular basis. So the challenge then became, once we had this differential, it was how could you not be doing integrative medicine? How could you not be doing functional medicine? Because, oh, by the way, part of the immune system is the gut. And so you've got to heal the gut as part of what you're doing. And especially if you're doing Lyme disease and you're doing all these antibiotics, you've got to be protecting the gut and healing the gut in the process of this. And so this whole thing started to evolve where what we were looking at was both the innate immune system, the function of the gut in terms of playing with them, in terms of the balancing of the immune system. But then what came into play was, and so I wrote my first book, and my first book was Total Recovery. Perhaps a touch of hubris there, thinking that we actually had figured out the problem of what was causing chronic pain, neuroinflammation. Well, there's a little bit more to it than that. The next level that we started looking at was autoimmune disease. And what we did in, again, another study group with colleagues from Georgetown and NIH, and then in May of last year, we held a conference at Georgetown on autoimmune encephalopathy of infectious etiology. So specifically, we're looking at how Lyme disease and strep and Epstein-Barr and a number of other infections potentially turn on the autoimmune system. So now we've got a different picture. It's not just the toxin. It's not just the given assault that set off the immune system, but there's a point at which the immune system itself becomes the problem. So the innate immune system fires up and keeps firing up when it has no business doing so. What's the innate immune system? Think of them as the guys you've brought in. You've had storm damage to your house. You've now brought in these guys who have to renovate the house. Well, the first thing that has to happen is you need somebody to clear up all the mess. That's your innate immune system. It comes in, it creates a parameter, it tears up the walls, it tears up the flooring, everything that was damaged, and sets it up so that then it sends out a bunch of signals that call in the private contractors who come in and then repair everything, unless they're overstimulated or continually bombarded. In which case, then aside from renovating that living room, they're now going after your dining room, your kitchen, your study. They're taking out the house. And so you've got to do something that also quiets down the innate component of the immune system. Now, the same thing happens with the acquired immune system. There's a subgroup of people where the acquired immune system comes into play. Well, these are the smart guys, right? They're supposed to be smart enough that they target a very specific thing, except that they get generalized. And when they get generalized, they start attacking your own tissue. And again, where you went from getting raccoons that had invaded your house and were only occupying the living room, and you had hired the guys who were specialized in going after raccoons, the adaptive immune system, they also say, wait, that couch looks a little bit like the raccoon where it was hiding, that chair. And so the next thing you know, you're having to buy a new couch in addition to getting rid of the raccoons. Well, and then they go a little more generalized. The wall over there in the back looks like a raccoon. It starts tearing down the wall. So now we've got this great big problem going on. So now we have a brain truly inflamed. So we've got the initiating problems, the mold, the toxins of various types, the concussion, whatever the assault was that set this thing off, and now we have the immune system going rogue. How serious is that? Study just came out, 2 studies. One study looking at Alzheimer's disease, looking at beta and tau tangles, okay? For the longest time, so much research has been devoted to going after that and assuming that that would fix Alzheimer's. It's a problem. There's an old study looking at nuns and priests where they discovered a great deal of beta and tau tangles, but none of them had Alzheimer's. And the question was why? Well, the answer is just shown up probably in a study just last year where they were looking at microglial activity, and what they found was dramatically elevated microglial activity in people with Alzheimer's. So, if you had beta and tau tangles, but no inflammation of the innate immune system, you did not have Alzheimer's. If you do have beta and tau tangles, and no inflammation, no Alzheimer's, if you have the inflammation, Alzheimer's. Indeed, a study just completed going after the beta tau tangles, and they just shut it down because it was ineffective. It's not working. So we have a new target, and the target is the innate immune system that we have to figure out how to quiet it down. And what we're finding is the innate immune system does a couple of things. One is it can develop a type of PTSD where because it's been hit so many times, it's hyperreactive and it goes upregulated much faster. The second thing it does is there's a point at which it gets stuck It's in its inflammatory pattern. When it gets stuck in that inflammatory pattern, things like Alzheimer's, things like MS, things like Parkinson's develop. And so now we've got a whole different picture. But so when we're treating, we have to go after the causative agents, the toxins and whatnot, but we also have to pay attention to see when the immune system's been hyperregulated and go after that as well. So what I'm presenting on this afternoon is exactly this material. The challenge has always been is we've looked at depression, we've looked at chronic fatigue syndrome, we've looked at chronic pain syndromes as diseases. They are not. What they are is symptoms. They're symptoms of an underlying neuroinflammatory disease. Now, that neuroinflammatory disease may involve only the innate immune system. That neuroinflammatory disease may involve both the innate and the adaptive immune system. And that neuroinflammatory disease inevitably involves mitochondrial dysfunction. And I haven't talked about that earlier, but that's a third leg of the stool that has to be paid attention to. So it's actually making a four-legged stool. The first leg is what is it that caused the problem? And inevitably it's several things. So you've got to go after mold, you've got to go after Lyme, you've got to go after whatever is there and needs to be addressed. And some of my toughest patients are those who have been abused in childhood. That sets up a chronic inflammatory process in the central nervous system, that sets up a dysfunction of the immune system, the end result of which is these people overall are much more susceptible to autoimmune diseases, to cardiac diseases, to diabetes. Okay? And when those people get Lyme disease on top of that, or they get mold toxins on top of that, or they get Epstein-Barr on top of that, they are a much different picture to treat. So you've got to be able to prepared to treat both the psychological component of what's going on in order to quiet this down, as well as the physiologic component, the toxins and other stressors that have come into play. That's the talk, and I'm hoping people will enjoy it this afternoon.
Well, Ed, good luck with your presentation this afternoon, and thank you so much for taking the time to join us today.
Thank you. I'm honored to have been invited to speak and delighted to have the opportunity to talk with you.